Good morning. Thank you, Dr. Mahanto, for this opportunity. A wonderful course, and we look forward to having these presentations every year hereafter. Now, I'll be talking on Phaco in a small pupil. Okay, so Phaco in small people and IFIS can't be very far behind. So it's all about anticipation, identification, and management. I'm Suven Bhattacharjee, and I do have a financial interest in the BHEX pupil expander. Now, why is small pupil such a big problem? When the pupil size comes down to 4 millimeters instead of 8 millimeters, the surgeon's viewing area is reduced to a quarter. And that's a significant reduction. So again, there is the issue of IFIS, which is intraoperative miosis and iris prolapse, which is absolutely unpredictable. And let's just see if iris hooks can prevent it. Now, this is a presentation which I did in 2013 in the ASCRS, and it was sent around all over the world. So this is a case of severe IFIS. I already have iris hooks in place, and yet you look at the iris, it's prolapsing from every port, and it's absolutely frayed even before I finished my capsular excis. This was a disaster. So hereafter, every time my Phaco probe entered, the iris was sticking to it. And you can see that knuckle of iris over there. We did get away with this case, and we put a lens in the bag. Nevertheless, what I wanted to show was that iris hooks really do not prevent. So do pupil expanders or rings prevent? No, that also does not. So you can see the iris prolapse to the side port, and in a moment you will also see the iris prolapse to the main incision. So it's not about IFIS has three components, of which we are concerned about miosis and iris prolapse. As far as the miosis is concerned, iris hooks and pupil expanders provide a constant pupil size, which offers good visibility for safe phaco emulsification. As far as the iris prolapse is concerned, no device can help. It depends on the IFIS severity and the pathological damage to the iris. So if you do not have iris prolapse on a given day, it's just that it was milder version of IFIS, and no credit to the device as such. One question I always ask, I request you, ask yourself, if you are the patient and going under the scalpel, what would you like? The surgeon to show his bravado and skills and not use a device, or be safe and use a device? So keep that consideration in your mind when you're dealing with your patient as well. Now, this is the long list of predisposing conditions which can cause IFIS. So no amount of history taking can really prevent surprises, and it's an absolutely unpredictable situation. So can we see the pre-op pupil in the OPD and come to a decision as to whether we'll have IFIS or not? Unfortunately, no. For a pupil 7 millimeter or smaller, the risk of IFIS existed, okay, regardless of alpha blockers. Now, the risk of IFIS is much higher in India. It's a wonderful paper, it's a landmark paper, and hypertension is often a cause of IFIS as well. So surgeons fortunately have lowered the threshold for using a pupil device because IFIS is unpredictable, because patients' expectations have become more exacting, and of course the unforgiving nature of premium IOLs. So this Chang and Campbell told us in 2005 that unlike the non-elastic myotic pupil, the IFIS pupil immediately snaps back to its original size following attempts to stretch it. So which brings us to the conclusion that mechanical dilatation of the pupil does not help in IFIS. It does help in the rigid pupil. So we must keep that in mind. Now, so the pupil is only of two types. One, the small pupil. One is elastic and the other is non-elastic. The elastic pupil is much like a rubber band. It's stretchable, so any device will work. Whereas the rigid pupil is like a string. It's tearable or breakable. So you need either a bulky device or two Kuglin hooks to stretch it before you start doing the surgery. So you have to be watchful of that. Now, before starting, we could check the elasticity of the pupil. Just inject BSS through the side port and inflate the AC. If the pupil expands momentarily, you know that we are dealing with an elastic pupil. And if it does not, like in this next case, you may inject as much as BSS you want. This pupil does not budge, so you know it's a rigid pupil. It's a good idea to use two Kuglin and produce a controlled, pupil expansion. Now, once you have done that, you have a situation which is now renders this pupil into a kind of elastic pupil. So what matters most is the elasticity of the pupil and not the size. So how big do you want the pupil to be for a safe phaco emulsification? Now, if you ask ourselves, if we are assured that the pupil will not come down less than 5.5 millimeter, I guess all of us can do a surgery. So, I'll be on. So, BHEX gives you a 5.5 millimeter pupil, and even if you're using iris hooks, I would strongly recommend that you do not move more than 5.5. So this is a wonderful video by Dr. Deepak Magur. It's a rigid pupil pseudofixation. There's a little bit of stretch done, and now that pupil is a little elastic. Now you can tuck those flanges of the BHEX very easily. And this is a pretty hard cataract, so if you had any doubts as to how large a pupil you need, 5.5 I think is more than adequate. So if we could move further, yeah. And it's good for all stages of nucleus disassembly and IOL implantation. One good tip in small people is you keep the anterior chamber underfilled with viscoelastic, allow iris bowing, and so that it helps in hooking the iris if you're using iris hooks or placing the flanges or any part of the pupil expander. Overfilling the anterior chamber actually is counterproductive. You're flattening the iris against the lens capsule, and that leaves no room for the device. Now, for the BHEX works very easily for any any incision 1.8 and above. So you can easily put the device inside. Like I just showed, I injected viscoelastic under the pupil margin, and it's a very thin device, and you can tuck the flanges, alternate flanges under the pupil margin, and you have a very helpful 5.5 millimeter pupil for all your surgery. This can, practically allows you free surgery at every stage, including IOL implantation. And removal of the device is very easy. Just hold one of the flanges, advance it centrally, disengage the two notches on either side, and just drag it out, and it comes out. Now, if you want to inside the device through a 1.2 millimeter incision, you could do that as well. Just a little change in technique. If the flange is lying across the incision, it is difficult to put it in. It's a 1.2 is a very small incision. But if you hold the flange, like I said, if you hold it in the middle, it will not go in so easily. But if you hold the flange at its end, so that it's aligned more to the incision, it just goes through. And you can put it in even through a 1.2 millimeter incision. No device in the history, no pupil expander in the history of ophthalmology has been able to do it so far. Now, removing the BHEX. You could remove it through even a 0.9 side port incision. It's as thin as a human hair. So there you just grab the flange over there, the corner, advance it centrally, disengage the two notches on either side, and just drag that device out, and it comes out very easily without any resistance. Now, a few words about iris hooks. I'm sorry, this is a very old video. I do the side posts first. I do not overfill, like I said. Now, I like to keep the parasite a little clear corneally and posterior directed, and I like to also make marks in the conjunctiva, small nicks over there, because sometimes it gets very embarrassing, you can't find those incisions. Now retract that stopper well in advance, and because that can get embarrassing if you're not retracted the stopper, and then hook, and do not stretch it all the way. Just do a partial stretch, and I do the Phaco incision. And do not get carried away. If this is a very large pupil. This is very old. This is actually taken from a VHS cassette. I have not used iris hooks in a very long time. And must remember that the pupil margin is antiflexed. The pupil margin is at the limbal plane. So any instrument which goes in is going to push the iris. So be very mindful of that. While removing, just hold the stopper, advance the hook a little into the car, and just pull it out. The hook just straightens momentarily and walks out of the incision. It's a very easy thing. No highly skilled techniques required. Now, there are certain concerns with iris hooks. There are multiple incisions. The risk of infection, at least theoretically, exists. Iris sphincter damage is there. The corner space is wasted in iris hooks. So that's actually a shame. And like I said, the pupil margin is elevated to the limbal plane. So that, again, comes in the way of your devices. And, of course, there is a publication which does say that iris hooks take longer than pupil expansion devices. And if you had a bad IFIS case, you would have marks like this at the end of the surgery, up in the post-op period. So for a device in IFIS, we require something which goes through small incisions, has a low vertical profile, can exit through the side port. So iris hooks and BHEX pupil expander both fit the bill very well. Now, when it comes to intraoperative meiosis, now the BHEX again serves the purpose very well. With the Malugin ring or other pupil expanders, you really can't see the gap on the side which engages the pupil margin, so you never know when you're catching the capsular excess margin. But with the BHEX, what you can do is you can just inject a little viscoelastic in front of the capsular rim, and as you tuck those flanges, you can push it to the periphery, and you have instant confirmation that you have not engaged the capsulorhexis margin. If you have, you can just withdraw a little and again go back. So you're doing that all on direct visibility. Can I have audio, please? Audio. So it's a privilege to have Dr. David Chang.
This ring is very popular in Asia, I believe, and in some European countries. And again, it's FDA approved, and he calls it the B-hex ring. And it's really, really thin. So this ring comes out really easy. It's flimsy, it's thin, and we pull it right out.
Now, this is also available on the AO website. This was a wonderful case by Dr. Michael Henry and Deepak Edward, where the BHEX was used in a pre-existing tube shunt, and a single incision was used, and look how the flanges are maneuvered around the tube shunt. There it is, the flange is held, and it's going around the tube shunt and tucking under the pupil margin. So this is wonderful. It's available on the AO website even now, and that facilitated the Phaco surgery very much. So now, choice of pupil expander. When I have intraopmyosis, I would recommend iris hooks or the BHEX because they serve the purpose very well. If I have a subluxated cataract, there is no second thought about it. I would use iris hooks only because you can, use it segmentally. I can expand the pupil wherever I want. Clock hour wise, I can control it. I would strongly encourage you to look at this PDF, which has got video links. This is very informative. Thank you very much once again, Dr. Mahanta, for this opportunity. And this is also available on eoftha.com, very easy, freely available. Thank you very much.